everyone. Welcome, and thank you so much for taking the time and enduring the LA traffic to get here tonight. We appreciate it, and we hope that this is helpful. And just as Michael was saying, if you could hold your questions until the end. A lot of the time, some of the questions that we have might be answered later in the presentation, and if you need to, write them down just to make sure that you remember, because we definitely want to answer any questions that you have. Let me know if you can't hear me. I will try my best to project. I'm fighting a bit of a cold too, so hopefully I don't cough through this too much. All right, so we want to go over and give you all more information about borderline personality disorder and the signs and symptoms of this disorder, as well as treatment options. So how many of you are familiar with BPD, which is the acronym there? So a good number of you. How many of you really aren't familiar at all, and this is really kind of the first step in learning more about it? Anybody? Oh, okay, awesome. Well, hopefully this is still informative. So first, what I'd like to do is kind of get some understanding from you guys. What do you know? What's the word? What do you guys know about BPD? Because there's a lot of misinformation as well as good information out there. So shout it out. What have you guys heard about BPD from any resource, from the media, from movies, from other providers, from loved ones or people you know? What have you guys heard about this disorder?
Jodi Arias, right?
Jodi Arias?
Yeah.
What else have you heard? So there's people that are well known that struggle with this disorder for sure. What are some untreatable? Yes. Yes. What else?
That it's just women.
Just women, yes. I've heard that too. Mm-hmm.
People think they need to be scared of supposedly only women who have BPD.
Mm-hmm. Mm-hmm. Has anybody heard the dreaded M word, manipulative? Yeah? Yes. Yeah. Any other things that you guys have heard about this disorder?
So, confused with like bipolar?
Yes. Yeah, a lot of misdiagnoses. This.
I've heard clinicians say or instructors say you don't want them as a client.
Yeah, unfortunately I have heard that too. Yeah, which is very sad. So this just goes to show that even in a small room, we've all heard things that are common misconceptions about this disorder. So you guys named some of these. I wanted to put some up here. People with this disorder are manipulative. This in itself is it just holds such a stigma, that statement. And unfortunately, it often leads to people not getting the care that they need. And we really here try not to use this word, because really what's going on, and I'll talk about it more, is that people are just trying to get a need met. And they're often not doing it in a way that's super effective or that's actually meeting the need that they have. And unfortunately, it's seen as manipulative. It's a common myth. BPD is not treatable. So you guys notice that has been a myth that you've heard. This is actually one of the most treatable diagnoses, which is wonderful, because another myth is that this is a life sentence for people who do get diagnosed with this disorder and have all these stigmas and misunderstanding about it. So we'll talk more about that in a little bit. BPD is an inherited disorder. So has anybody heard this one? No? So this actually isn't an inherited disorder. This is a disorder that we may inherit some traits of BPD, which might be like the way that you're kind of wired to experience emotions, and I'll go over that in more detail. But it's not just that. It's a nice little recipe. There's got to be more to it than that. So there's an environmental piece as well. So I'll talk about that later. BPD only occurs in women. This is another one that you guys said. That's not true. And I think that this is a really unfortunate myth, because what happens is that men often don't get the treatment that they need because there's this belief that it's only in women. And actually, it used to be, I think the DSM-5, the new DSM, which is the manual for making diagnoses, said that it's 3/4 women. It's actually now more 50-50 of men and women who have this diagnosis. So just knowing that, hopefully we can kind of shift the way that we approach this so men can get the services that they need as well. You cannot diagnose before the age of 18. This is another myth. Why do you guys think that it might be hard to diagnose this before the age of 18?
Because teenagers are very unpredictable.
Yes, exactly. Because when we go through the criteria, you might see that most of the teenage population could potentially meet this criteria for the diagnosis. The personality is still forming, and so it can be tough because things are changing so much. However, you can make the diagnosis before the age of 18, and there's a lot of merit in that, because if we can catch it earlier, then the person can get services earlier, and it might not be so impacting in life later. BPD is caused by a trauma. While a lot of individuals who have this diagnosis also have experienced a childhood trauma or a trauma in their life, that's not a requirement for this diagnosis. It's just a correlation. What is kind of required for this diagnosis is that the individual experienced an invalidating environment. So that piece will go in later when we talk about how this comes to be. But this is a myth as well. And bad parenting causes BPD. Oh my goodness, as a family class coordinator, when I go through the biosocial model, parents often say, oh, so this is my fault. And it's not true. There's so much that goes into it. And what can happen is that there's just a poorness of fit as far as being able to know how to respond to the individual's emotional experience in a way that's supportive. We often do the best we can and then end up inadvertently invalidating the individual. So it's not purposeful, we just don't know how to effectively support that individual's emotional experience. Okay, so some statistics. The average prevalence, and this is from the DSM, so the Diagnostic Statistical Manual, of BPD is 1.6% in the general population. It might be as high as 5.9%. That's a whole lot of people that are walking around struggling with this diagnosis. Intentional self-harm and suicidality are the behavior most associated with BPD. So most individuals that do have this diagnosis struggle with suicidal ideation or what's called parasuicidal behaviors, which is like self-harm behaviors. And this is really a means to try to manage emotion dysregulation through self-harm and suicidality. Symptoms of BPD typically reduce in middle age due to increased stability in areas of life such as relationships and vocation. So we do see that there is a decrease in people meeting the full criteria for this diagnosis later on in life. And part of that is because some areas of their life become more manageable and more stable. So the dysregulation that can leak into other areas when stuff's kind of uncertain and unsure isn't really present. So the struggle and the management of emotion dysregulation that's often ineffective isn't as present. So the individual might not meet criteria for this. BPD is often co-occurring with other disorders such as mood disorders, substance use disorders, and other personality disorders. So as was mentioned, it's often misdiagnosed. This is part of the reason that it's this lovely layered cake of different disorders going on. So you're trying to figure out what behaviors or symptoms are related to what diagnosis, how long have these behaviors been going on or these symptoms been going on, so we can make a more accurate diagnosis, which means the person's going to get more helpful services out of it if we know more accurately what the diagnosis is. All right, so let's talk about the meat and potatoes. What is the criteria for this diagnosis? What are the signs and symptoms that you or someone you know might be experiencing traits of this disorder or have full criteria? So there are 9 criteria for this disorder, but you only need 5. This is another reason that this is sometimes misdiagnosed, because if you do the math, and I'm horrible at math, so I looked this up, I'm going to be completely honest, this is 256 different combinations of criteria. So we could have this room, probably couldn't hold that many people, but we could have this building filled with 256 people who have this diagnosis but might be presenting quite differently. So it makes it hard to pinpoint. So let's go through what this looks like. The first one is a pattern of intense and unstable interpersonal relationships. This is really kind of a corner piece of this diagnosis. So you might notice that an individual gets into relationships very quickly, or they put somebody on a pedestal and really just kind of idolize them. And then when there's some kind of interaction that doesn't feel good, then the individual will then devalue that person. They're the worst person on earth. They're, somebody I don't want in my life anymore. Frantic efforts to avoid real or imagined abandonment. This is also a really important criteria that we see, because this can impact the other criteria. It might lead to the other criteria as a way of managing this. So it doesn't have to be that there's actually a threat of somebody leaving. It's real or imagined. There could even be an experience earlier in the person's life where it makes a whole lot of sense that that fear is there. However, it then becomes the lens that the individual is kind of seeing everything through and feeling really intense emotions around worry of somebody leaving them, which it causes really intense dysregulation. And then we might see other of the criteria up here as a means to try to manage that dysregulation. The third one is identity disturbance or problems with sense of self. So this can look like a couple different things. Often the person might not know what their values are. Their goals might change quite often. They may do what we call a chameleon-like experience, where they kind of take on the aspects of the group of people that they're around, and not really be something that maybe you have known as a part of their personality before. So they might try to connect and fit in, and try to have a sense of self through someone else's personality or traits. Impulsivity that is potentially self-damaging. Now, this needs to be in at least 2 areas, and it has nothing to do with self-harm or suicidality. So some areas of impulsivity might be gambling, might be promiscuous sex, it might be binge eating or substance use, risky driving, all of that. So it needs to be in at least 2 areas and not related to self-harm or suicidality. Recurrent suicidal or parasuicidal behavior. So again, this is something that we often see as a cornerstone of this disorder, is that all of this feels so unmanageable, the emotions are so intense that life feels intolerable. And this becomes some of the options for coping with that. The self-harm behaviors might be served as a means to try to ground from emotional pain. It might be a means to just know that you're alive. There's a lot of different functions. It could be self-punishment. There's a lot of different functions for self-harm behaviors. And the suicidal ideation is often around just life feeling so intolerable that this is the only option I know of because nothing else has worked. Affective instability. This means mood is kind of all over the place, can be. This is sometimes why bipolar comes up as an option of a diagnosis, because when we see that, that's often the first thing that we think of, because that's more of what we know of bipolar. So mood instability is a big piece here that comes with the emotion dysregulation. not understanding or trusting emotions or knowing how to manage them, it can be a bit of a roller coaster. So what we see on the outside isn't even an ounce of what the individual feels on the inside, and it's really intense and it feels very unmanageable. Chronic feelings of emptiness. This is also chronic feelings of boredom. Can be both things. And this, for most individuals that I've worked with, if they experience this, this is one of the hardest things to tolerate. It's even more difficult to tolerate than just emotion dysregulation itself, because the individual is struggling with feeling anything, and that creates a pretty deep sense of hopelessness. Number 8, inappropriate, intense, or uncontrollable anger. So anger, we see that in different disorders. With this one, the anger is really intense, and it could also be internal anger, like the quiet, seething anger, or the outward, explosive anger. So if you or someone you know has this diagnosis, but they don't outwardly show anger, ask about what goes on internally as well, because often there's some kind of intense anger going on, and it might be more focused internally. And then the last one, transient stress-related paranoid ideation, or severe dissociative symptoms. So this is also one that can get confusing if you have that layered multiple diagnoses going on, because PTSD has dissociation as well. So dissociation is when you feel disconnected from the present moment. That can look like a lot of different things. It could be where you have brief moments of zoning out, or you have, all the way on the other end of the spectrum, hours of lost time. And you can imagine, if you haven't experienced that before, how scary that would be. That all of a sudden you realize that you have no idea what just happened over the last several hours. And that is part of this diagnosis as well as PTSD. So while dissociation isn't an uncommon symptom for people to have, it's the impact that it has on everyday life for the individual. That's what we want to be mindful of. All right. Help. So, just to summarize it, we're going to look at this a couple different ways. What this term is, it's kind of not the best term. I have judgments about it. It's more of an umbrella term for a disorder of the emotion regulation system. That's really what it is at its core. And each criterion within this serves as a means to regulate emotions, or it's a natural consequence of emotion dysregulation. So if you can imagine constantly judging your emotions, not knowing what to do with them, they're really, really intense and they're all over the place, and you feel really hopeless about it, that could make you have low self-esteem and have an unstable sense of self. So you can see kind of how the criteria start coming to be when we have this pervasive emotion dysregulation. And if you don't know how to manage those emotions, and you discover that self-harm seems to do the trick, at least for a little while, that's another one of the criteria. So it's either, each criterion is either serving as a way to regulate emotion dysregulation, or it comes as an after effect of emotion dysregulation. So we're going to take all the criteria and mix them up a little bit. So Marsha Linehan, she is the creator of one of the therapies that is used to treat borderline personality disorder. And that's the type of therapy we use here, and I'll talk about it briefly near the end of the presentation. But she took all of the criteria and placed them into the different areas of dysregulation that they fall in for the individual. So with emotion dysregulation, which is kind of like that lovely umbrella, we have mood swings, so the instability of mood, and we also have the intense anger. interpersonal dysregulation. This is dysregulation within relationships. So within this, we see a lot of relationship chaos and the fear of being abandoned, whether that's real or it's an imagined fear that we have. Self-dysregulation. This is the struggle with identity and sense of self, and also those chronic feelings of emptiness and boredom. Behavioral dysregulation. This is where we see self-harm, suicidality, and impulsivity. So those behaviors serve as a way of trying to regulate emotion regulation through dysregulation of the behavior. So how we're trying to do it, how we're trying to regulate emotions. And then cognitive dysregulation. So this is where we see that transient stress-related dissociation or paranoia, so that disconnect from the present moment or the worry thoughts about, do people like me? I can't trust my emotions. What can I trust? And then also obsessions. So just because it's nice to have different ways of learning the information, this is a little illustration for this as well, that we have emotion dysregulation as kind of the umbrella over this, and it's the biological piece, which I'm about to go into. So the way we're wired is off a bit with how we're experiencing emotions as far as what the environment can support or knows how to support. So we have this interaction going back and forth. And then that leads to emotional vulnerability, which again I'll explain in the next slides. And that leaks in, that's why we call it pervasive, because it leaks into all these different areas of our life, of behavioral instability or dysregulation, interpersonal instability, self-instability, and cognitive instability. So how on earth does this come to be? So as I said before, this isn't an inherited diagnosis. This is something that we've got to have this nice little soup going in order for it to come to the surface. So there's a biological piece and a social piece. The biological piece interacts with the social piece. We're all wired differently. There's nothing wrong with that. If we're in an environment that doesn't know how to support that, over time it's going to have an impact. And the impact in this situation is that we get a disorder of the emotion regulation system. Whoops, I don't know what I did. Oh, okay. So there has been enough research on this that a model has been developed, and it's called the Biosocial Model. So this is the interaction between the biological piece and the social piece that leads to pervasive emotion dysregulation, aka BPD. So the first biological piece is that there's a high sensitivity. That means that it doesn't take much to experience emotions. It takes a lot less than other people who aren't wired this way. The threshold is low. Also, you might notice that you pick up on the emotions in other people in a more acute way than others might. So you're really sensitive and attuned to what other people are experiencing. The other piece is that there's a high reactivity. So it doesn't take much to experience emotions, and the experience is really big. It feels sometimes like a punch in the gut. You might have an actual visceral response to an emotional experience. And what happens here is that when we get really dysregulated, our ability to process new information, to think through about a consequence, to plan ahead, to mediate conflict, all of that is shut down because our emotional experiencing area of our brain has sent a tidal wave, a tsunami over our frontal lobe, which is where we can slow down and think about, okay, if I do this, then that might lead to this. Or slowing down and seeing that there, what else could I do to help not have things get worse. So that part of the brain is very much compromised. And then the other biological piece, so it doesn't take much to experience emotions. The experience is really big, and there's a slow return to baseline. So the individual who has emotions wired this way is going to have to really take some time to come down from that. And unfortunately, as we know, life doesn't stop. We might have to keep going. Maybe we're at work and something happens that's really upsetting, and we're trying to take our time to get back to baseline. But we have to go do something. And we go and we walk back out of our office, and something else happens. Somebody says something that is understandably really upsetting, and we're already right here, so it doesn't take much to bump right back up. So that is one thing that can be unfortunate, that you're kind of set up for the next upsetting situation if you're not able to do things to help bring it down and really give yourself that time to have the return to baseline. So that was the biological piece. Again, nothing wrong with that. We're all wired differently. But when we have an environment that isn't sure, even in their best efforts, how to support that, then we've got a tricky situation. So what can happen is that the individual is trying to express that they're having a hard time. And the environment, which can be caregivers, it can be school, it can be peers, any group that you're a part of, church, anything, expresses in some way that what you're feeling or how you are behaving is wrong. Your private experiences that no one else can know, because no one's in our own skin, you're being told that's wrong. So this happens often and over time. So your experience is rejected as invalid. This might be like emotional displays and or pain behaviors are met by punishment, and escalation is met by erratic intermittent reinforcement. So another example of this might be that you go and try to let someone know you're having a really hard time, and they aren't able to or aren't willing to support. They, for whatever reason, can't. So you up the ante a little bit, and behaviors get more intense. And still the environment isn't supportive of this in whatever capacity that they are. So maybe they tell you, like, stop, that happened 4 days ago. Why are you still upset about that? Something like that. Because remember, that slow return to baseline takes a while. And so then the person is so emotionally dysregulated that maybe they go towards self-harm behaviors to help regulate because the environment isn't helping. They're not meeting the need. So then the environment might see that, oh my gosh, they just cut their arm, and now they come to the person. And so that's the intermittent or erratic reinforcement might happen, and the individual starts to learn that this is how my needs can get met. I can only get my needs met when I'm hospitalized or when I need to go to the ER to get stitches for my cuts, something like that. So, do I have another thing here? Yes. Another form of invalidation can be expressing the ease of problem solving or oversimplifying it. Well, okay, I know that's upsetting, but just get over it. Come on, like your brother can get over it, like just get over it. Something like that. Because it's not that easy. If we could just get over it, we would. And I wouldn't have a job if it was that easy. I wish it was that easy. So an example of, I want to back up just a moment and give an example of what this might look like. So has everybody in here seen the movie Bambi, or most of you familiar with it? Yeah. So there's a really sad scene at the beginning of that movie, right? So imagine you're sitting on a couch watching, or a caregiver or a babysitter, whomever, is sitting on a couch with two children watching Bambi. And that really sad scene comes on. And one child, says, oh, that's really sad. And the caregiver kind of taps and is like, yeah, it's sad. And then the other child just gets so upset. They're crying. They can't focus. They can't stop crying. It hurts. They're really upset. And there's nothing wrong with those reactions. If the caregiver says, come on, it's okay, let's just watch the movie, that's not really attending to that child's emotional response in a way that feels supportive or validating. It's just a movie. It's fine. Come on, look, now Bambi's jumping around with Flower or whatever the rabbit or whatever it is. Did I get that right? Does anyone know? No, I don't know. The skunk. Okay, thank you. Thumper. Yes. Thank you. But if the person was able to say, like, pause the movie and talk to the child about it and say, I know, it makes sense. I know it's really sad to see that. Do you feel like you can keep watching? Do you want to do something else for a minute? Really responding to that emotional experience, that is going to feel more validating and that they're heard and understood. Because ultimately, and I'll go into this later, all we want as humans is to feel understood and connected. And that is the skill of validation, which is, I think, like magic, if we can do it. But we'll talk about that in a little bit. And an example of the environment, imagine we go to dinner and order spaghetti. And the waiter brings out the spaghetti and gives you a spoon. I don't know about you guys, but I don't think I could eat spaghetti with a spoon. If you can, you're pretty talented. And so you look at it and you're like, but I asked for spaghetti. I feel like they should have brought me a fork. And so you have the waiter come back. You get the courage up to ask for the waiter to come back. Sometimes that's uncomfortable. And you say, they brought me a spoon. Can I have a fork? And the waiter says, yes, let me get it. I'm so sorry. They go off, they come back, and they bring you a knife. You're like, what? What is this? And the waiter's just kind of looking at you like, okay, eat your spaghetti. And you say, I can't eat spaghetti with a knife. I asked for a fork. And now you're starting to get more upset because you feel like you're being really clear, but the environment isn't giving you what you're asking for. And the waiter goes back and he brings out a glass of water. And at this point, you're really hungry, you're tired, you don't get it. The waiter's getting frustrated, and it's just not going great. So that is an example, and hopefully it doesn't escalate more. Sometimes, it could. I know if I was really hungry and wasn't able to eat my spaghetti, I might get pretty angry. That is an example of what can happen in an invalidating environment, that the environment might be really, really trying to, often the environment is really trying to support and validate the individual and understand, and sometimes we just don't get it right. And unfortunately, when that happens enough, that's what leads to pervasive emotion dysregulation. So you can see that the waiter was doing his best and was getting frustrated and confused, just as the individual who was feeling they were being really clear and getting frustrated and confused, how that can be tricky. And I know that happens a lot with families who are trying to figure this out and manage it and just don't know exactly how. So one thing that is one of the myths is that this isn't treatable. Not true, I'm happy to say. What's the prognosis? This is known as one of the, a good prognosis diagnosis, one of the best. And that's really hopeful. And that comes from research that shows that if you're able to get the support that you need and the services that are helpful for you and stick with it, that there's research shows that over 2 years, I know that sounds like a long time maybe, there's a 50% reduction in those who meet the full criteria for this disorder. So that doesn't mean that the traits aren't still there, because they are. What's different is that the individual now knows and has insight into their experience, and they have tools that are more effective to manage their emotion dysregulation, because the way we're wired isn't going to change. What can change is how we respond to it. So one thing to keep in mind, for those of you who may be trying to figure this out a little bit more, learn more information, is that treatment's not linear. It has peaks and valleys, and that's okay, that's normal. Because sometimes, if we're ever working on changing a behavior and we notice that we have days that it's harder to do that, or we go back to old behaviors, that doesn't mean it's a loss of progress. That just means we're having a hard day and we're going to come back and try again. So relapse in symptoms does occur, and especially when it's a new situation that the individual is trying to figure out how to apply the new coping techniques that they know to a new situation. It can be tricky to get your footing when you're not familiar. Like, this is new. How do I do this? And higher emotional involvement of key loved ones has been shown to make the prognosis even better for the individual. So there's also some myths that say, the family shouldn't be involved in the treatment of someone who has the diagnosis of borderline personality disorder. Really, it's quite the opposite. And being one of the co-leaders of the family program here, I have seen it be a tremendous support for the individual and the family. So we'll talk about resources as well in a few minutes. So having talked about the social piece of the biosocial model, the invalidating environment, I want to give you guys a little bit on what validation looks like. Because like I said, it can be like magic. It really can. If we're able to validate somebody who's struggling, even validate ourselves if we're struggling. So validation is the act of identifying and communicating our understanding of what another person is expressing through words, through or body language as it's happening in the moment. And one thing that I want to be clear is that if we're acknowledging someone's experience, doesn't mean we approve or agree with it, because sometimes that's where we can get stuck. It's that we're saying, I see you, I hear you. I might not understand exactly what you're going through. I want to try to understand. So it's being with them in that moment. So verbal validation, so saying it out loud, includes using factual observations to state what our understanding is of the other person's experience. So the example here is, I hear you saying that you're feeling frustrated. So you might just say back exactly what you hear the person saying. And that can be a great, great start to de-escalating emotion dysregulation, to showing that you're interested. Another way, if you feel stuck, is asking more questions. Oh, so when that happened, did you feel frustrated if they didn't say that? Or, were you scared? Were you angry when that happened? Or what did you do after that? So showing interest. And behavioral validation is how we demonstrate validation through our behaviors. So this could be actions or body language. The example here is like leaning toward the person, nodding and making eye contact. You all are validating me wonderfully right now because you're making eye contact and nodding. It can also be if somebody's crying, getting up and giving them a box of Kleenexes. That's showing that you're acknowledging their experience. And you don't even have to say anything. That feels good. So why do we want to do this? What happens sometimes, and this is such a normal urge, I just want to say that out loud, is that we move into problem solving really quickly. So if you are the loved one of someone who's struggling with emotion dysregulation or BPD, then of course our go-to is going to be, how can we solve this? How can we make this stop? And often that is something that we don't even need to go there. We don't even need to do that, at least not initially. What the person really is craving is to be understood as best as we can to be heard and understood. So problem solving can sometimes feel invalidating. Validation can de-escalate intense emotions. So we don't even sometimes have to do anything other than listen and try to understand, and the intensity of the emotion can come down. So if you can imagine a time that you weren't feeling great or you're having a hard time and somebody just really got it and felt like they were really with you in that moment, you can imagine what that feels like. It just feels good to have somebody understand and connect with you. And validation improves our relationships by showing that we're listening and that we understand. So if we have a relationship, I mean, this is the age of smartphones. If you're out with friends or with a significant other and you're at dinner and they're just on their phone and you're talking to them, that doesn't feel very validating. That kind of stuff, not validating, not paying attention, not being in the moment, that damages relationships over time. And so validation improves our relationships because we're showing that there's that importance to understand. So just to give the other side of this, so we know what to be on the lookout for, because we all can inadvertently, on accident, invalidate. This can look like dismissing or judging somebody's experience or criticizing their experience. An example is you shouldn't feel that way. That wasn't that big of a deal. That is a person's own experience. We might not agree with it, or it might not be something that we might feel. However, it's what they're feeling, and they're communicating it to you. So we want to acknowledge that. Invalidation hurts. It does not feel good. And often what happens is the emotions get more intense. They don't come down when somebody says, it's dumb that you're upset about that. If you can imagine hearing, like, you shouldn't feel that way, you're wrong, that doesn't make you feel better. That probably makes you feel worse on top of what you're already feeling. So it often increases the intensity of emotions. So let's do a quick guide to validation. Because again, I want to give you all some ideas for how we can do this. So the first is just pay attention. Be in that moment. So you're looking at what the person is expressing in their emotions, their thoughts, their goals, desires, efforts, effective behaviors. So for example, if a client walked into group and was really upset, threw their stuff down because they just had a really, really tough session, and they started yelling. That seems like a situation where it might be hard to find something to validate, right? Remember, validation doesn't mean we agree or approve of what happened. We're trying to demonstrate we understand that they're having an experience. So if I was to try to pick something out of that list of things to acknowledge, I might step out with the client, which is a form of behavioral validation. I'm showing, you're having a hard time. Let me give you some space for us to talk about this. And even if they don't even tell me what's going on, I can validate by what I've observed, that it looks like you're really having a hard time. What's going on? So even though I don't agree, and I won't validate that they came into group, threw down, disrupted the group, threw down their binder and got really upset, I'm not going to validate that, but I will acknowledge that, whoa, it looks like you're really, really struggling. Let's talk about what's going on. And that's validating and acknowledging that there's an emotion happening. So if you ever feel really stuck in a situation where you're not sure what to validate, I try to pick one or two things that I want to try to keep in mind. I can always validate someone's emotions. Anything that's a private experience to a person, you can always acknowledge and validate that, because we can't possibly challenge, really, because we don't know. We're not in their skin. So thinking of one or two things that you can pick out to say out loud If they say something out loud, like, I just had a really, really hard session, then we can say that back to them. Okay, so really, really hard session. Yeah, I can understand how that would be upsetting. So when the person's finished talking, that's when you share what you understand from their experience. And again, if you feel stuck, share what you observed in step 1 and or ask more questions to get a better understanding. Like, okay, what happened? What happened in session? Because I can tell this is something big. Because you normally are in group on time and asking questions in group and participating. This is totally, different. And be open to feedback. Number 4 is really important because validation is only validation if the person receives it that way. So I've had times where I've given what I thought was the best validation ever. I was really proud of myself, like, really validating. And the person said, no, Kate, that is absolutely not what I was saying. So we gotta be really open to feedback and say, oh, okay, missed the mark. Can you tell me more about what was happening? And sometimes we miss the mark a lot. And that's when you ask and say something like, I really want to understand, or I'm trying to validate, I know it's not hitting the target. Can you tell me what might feel more validating? So get some understanding from them. And the last one's also important because, as I said before, problem solving can feel really invalidating. If we don't spend time acknowledging and accepting the emotion experience, then that can feel invalidating of the experience itself. That doesn't really matter. Let's figure out what to do next. We got to get rid of these emotions, which is part of the problem. So before going to problem solving, asking, hey, I have some ideas. Like, I know that the session was really, really hard. I have a couple ideas. You want to talk them through? So just inviting them to problem solving or seeing if they're open to it. So how can I help? So if you're, I don't know why that did that. Oh well. If you're struggling with trying to figure out how to support, maybe you're part of the environment like the waiter at the restaurant that's trying and just missing the mark. So how can you support somebody who is struggling with either traits of BPD or has a diagnosis of BPD? The first one is to encourage your loved one, if they're not already doing it, to get professional support. Because what so often happens with the family is there's a lot of burnout because the family is trying to be the clinical support, and that just doesn't work for anybody involved. So what I wrote there, you can't be the clinical support, you can support the clinical. So if the person is getting treatment somewhere, that you can support that work, but we can't be our loved one's therapists. And the second bullet point there, go against the urge to problem solve. So again, it's such a normal response to, I want to help my loved one get relief from this. It looks just intolerable to feel this way and to be struggling with this. And it's important to try to practice validation in the way that I described in the last slide. So try to practice that rather than going toward problem solving. And then the last bullet point is to get support yourself. So if you're somebody who is very actively involved with a person who is struggling with some of these behaviors or the diagnosis, get support yourself, because it's hard to navigate this with not really knowing what might be the most helpful way to support. So I'm going to go through a bunch of different resources to give you guys some ideas and options, because it's so important to not do this on your own. That's a myth that we often hold, is I've got to figure this out on my own, and there's just so much support that's out there. We don't have to work so hard to navigate this when there's a lot of different supports out there. So with the first one, not sure why there's animation on that first bullet point. So the first point in how can I help? Well, encourage your loved one to get treatment if they aren't already getting clinical support. So there's different levels of treatment. The highest level is hospitalization. So that is if the individual is a danger to themselves or others, that they might need that kind of support, at least temporarily. Hospitalization is not a long-term solution. It's a crisis management. Residential. So that's like this program. Michael, are you going to talk about the program?
Yeah, and then we'll
Okay.
take questions after.
Okay. So you'll hear more about this program, and there's different levels within Clearview, and of course there are other options out there as well. But residential is a great way for an individual to get a lot of support around this diagnosis and these symptoms around the clock, and be able to learn new ways to cope with what comes up for them. Intensive outpatient, this is a lower level of care. It's about 3 to 5 days a week, so it's not as much of a commitment. It's for people who are able to have less clinical structure and still kind of go to groups and have therapy throughout the week. So often we'll have individuals start at residential, and then as behaviors and symptoms get more managed, they'll step down. So we'll go to the lower levels of care. And then outpatient, which is the lowest level of care, where you might meet with a therapist once a week. And dependent on the type of therapy you do, if you do dialectical behavior therapy, you'd go to a skills group once a week as well to just try to maintain the knowledge that you have about how to manage the different things that come up for you. So I've got lots of resources for you guys. So there's some really great online literature. There's also some really not great online literature that reinforces some of the myths that we talked about at the beginning. So I'm going to give you some that I know are chock full of great resources. So borderlinepersonalitydisorder.com. This is the National Education Alliance for Borderline Personality Disorder. This is their website. So they have tons and tons of great resources. So they have articles, they have different videos, and they have videos that are like lectures. They have videos that are simulations, like examples of how to validate. They've got all sorts of great stuff. They also have a group on there called Family Connections that I'll talk about in a minute. Behavioraltech.org. This is the creator of DBT, Marsha Linehan. This is her website. So lots of great resources, and they're geared toward that type of therapy, so dialectical behavior therapy. NAMI.org, National Alliance of Mental Illness, great website. Lots of information on there as well. And BPD Demystified. This one addresses a lot of the myths. So if you want to go back through the ones that I talked about, I think there might even be a couple on there that I didn't include that you can go through and become more informed on some of the common myths out there. And there's other resources as well. So that's the online literature. The actual physical books that we so often don't really use anymore. We all have Kindles and all that. These are some of the ones that I've read some of these, and they're often often referenced as helpful from individuals and families who are trying to navigate this. So just to go through a couple, like The Buddha and the Borderline by Kira Van Gelder. This is it's a woman's story of her experience with BPD. This is a great read. It can be difficult to read too, especially if you experience the symptoms or you have a loved one who does, because you really can connect and feel her struggle through navigating this. Let's see. Some more literature, some workbooks that you can get and work through. Dialectical Behavior Therapy by McKay. This one I think is really great. It's easy to go through. It's a snapshot of the DBT manual, so this one I think is really user-friendly. And lots of other ones on there as well. Now, resources in the community. I know some of you came from pretty far away, so the resources may be different in your area. You can find them online, and you can Google it, or the NEA BPD's website, that first online resource for online literature that is in your packet. They list like Family Connections and Teleconnections. They run those programs, so you can look and see if there's a chapter in your area or apply to get into it. So Family Connections is a really wonderful resource for people who are trying to figure this out and navigate and be more supportive for their loved ones. It's a 12-week course, so that's a pretty big commitment, and it's so supportive and informative. So again, you have to apply to get into the class, fill out an application, and find one that's in your area. It's a wonderful resource. I highly recommend it. Teleconnections is another great resource that's pretty similar. However, it's a conference call, and they go over different topics. So it's not like the structured 12-week format. They're going to go over lots of different topics that are really salient, really important to just learning more or resources for support of yourself or your loved ones. Other support groups, there's Al-Anon can be helpful if your loved one also uses substances. CODA, which is Codependence Anonymous. This one is something that is really pretty common. It's part of the interpersonal dysregulation, is that there's often some codependency, so really kind of getting entwined in each other's lives, for better or worse. And this is a great support group that can help learn more about that and learn how to navigate that. And low-cost treatment, D.D. Hirsch Mental Health Services and Edelman Westside Mental Health. So these are actual treatment centers you can go to that are in the area, that are local. So some of the treatment approaches that have been known to help with treating borderline personality disorder are Dialectical Behavior Therapy, DBT. That's what we do here. This one has the most research supporting it. So all these modalities have shown that they're effective in treating borderline personality disorder. DBT has shown the most research backing up the efficacy of this approach. Mentalization-based therapy, schema-focused therapy, and systems training for emotional predictability and problem solving. So all of these modalities, it just shows, there's options out there. That if you or someone you know is really struggling and could benefit from getting more clinical support, there are options, which is great because, again, a lot of the behaviors that serve as functioning in the emotion dysregulation, like self-harming and the chronic suicidality, is because it feels like there's no option. You don't know how to manage it. Oh, all right. So that is it for my part. So.
Yeah, I think there's just one. Yeah, thank you.